I'm not calling you Babs. And even the Babs is
joining us this afternoon, and I'm excited to welcome distinguished delegates and civil society to today's session. We are convening today on the margins of the 78th Annual World Health Assembly to harmonize a shared agenda and focus on how to deliver on universal health coverage in this current moment. We are seeing a global pushback against gender equality and the principles of human rights to health, which are inextricably linked. My mandate as the Special Rapporteur on the right to health, I have investigated the right to health through various lenses and recommended a human rights approach for many of the thematic areas. Recalling the political declaration of the high-level meeting and resolution adopted by the General Assembly in 2019 on universal health coverage under the theme Universal Health Coverage, Moving Together to Build a Healthier World, I stress and underscore that universal health coverage is fundamental to reducing health inequalities, ensuring just, peaceful, and inclusive societies. The world is experiencing protracted war, humanitarian crisis, economic crisis, climate crisis, genocide, which have all had an impact on the right to health, reminding us of the interrelated human rights issues that operate at different levels in clinical care, at the level of health systems, and in underlying determinants of health. Political determinants of health in an era of pushback against gender equality and human rights are thrust center stage as leading causes of inequality, violence, stigmatization, discrimination, and criminalization. All are incompatible with the realization of the right to health and therefore impact universal health coverage. Delivering on UHC in an era of pushback against gender equality and human rights must consider that every human being is entitled, with no discrimination, to the enjoyment of the highest attainable standard of health and also a life conducive to a living of dignity. The right to health contains freedoms and entitlements, and the freedoms include the right to a system of health protection, which provides equality of opportunity for people to enjoy the highest available standard of physical and mental health. And so we must speak out against how the anti-rights and anti-gender threatens to reverse the gains made on UHC, threatens to reverse the gains made against gender equality and sexual and reproductive health rights across the entire globe. A human rights approach to universal health coverage in this moment of pushback against gender equality and human rights must center the key principles of non-discrimination, equality, meaningful participation, transparency, accountability, and these are not just mere aspirations, they are non-negotiables to the realization of the obligations under the right to health. And so I call on all of you as important stakeholders to pay attention to the situation of groups in vulnerable and marginalized situations, such as, but not limited to, children, adolescents, women and girls, persons with disabilities, migrant people, refugees, LGBTQIA+ persons, and older persons. We have learned that prioritizing one right of one group of rights over another leads to detrimental outcomes and systemic violations of human rights. I wish to call for a review of the systems we have inherited, those who those systems harm, those who get left behind or continue to be made invisible. We must move to a bold reimagining of public health governance and international solidarity. The extent to which human rights are respected, fulfilled, and protected, and concrete and formidable pushback on anti-gender and anti-rights movements will ultimately determine the success of universal health coverage. Thank you very much.
Thank you, Dr. T, and welcome to all of you. As we know, gender equality and right to health are fundamental human rights. Everyone, including girls and women, and all gender diverse people need to remain healthy and able to access the full spectrum of healthcare services without any stigma, discrimination, prejudice, or fear of criminalization. UHC is an important step towards ensuring health for all. But UHC alone is not enough to ensure that everyone remains healthy and disease-free. We need to dismantle patriarchy and access barriers related to gender to ensure that girls and women and all gender diverse peoples are able to access existing health and social support services when and where they need them in a people-centered and rights-based manner. USC is also not enough by itself because the nexus of capitalism, fundamentalism, militarization, and patriarchy is not only threatening gender equality and human rights, but also fueling climate disasters. And women and girls face graver consequences of climate change as compared to men. Similarly, girls and gender diverse people in the global south are far more they suffer far more severe impact of climate change compared to those in the global north. Until our health responses are rooted into a feminist model, which is grounded in development justice, we will not be able to ensure health for all. We also need to ensure that racial equity and gender justice drive our health responses to serve all, where no one is left behind or deliberately silenced or predictably unheard. Anti-rights push is further exacerbating gender inequalities and violations of human rights. We should not forget that those who are left farthest behind are first reached with the best of health and social support services in a gender-sensitive and rights-based manner. Now we will have a few short video testimonials of people on the front lines from Afghanistan, Iran, South Sudan, and India. We will be listening to Parveen, a lesbian partner who is now in Iran, and her lover Mariam, who has been arrested by the Taliban in Afghanistan. And Namath, the first gay person who came out openly in Afghanistan. We will also listen to Rachel Adao, Executive Director, Women Empowerment Center, South Sudan, Daksha Patel, who is from the National Coalition of People Living with HIV in India, and Maya Ranavre, President of Association of Persons Affected by Leprosy.
سلام امیدوارم همگیتون خوب باشین من پروین
Hello everyone, my name is Parveen. I was born in Ghazni province of Afghanistan and raised in Kabul. Parveen is a lesbian Afghan. She narrowly escaped persecution and arrest and detention by the Taliban on March 20th, and she's now in Iran because she believes that she is a voice and a vessel for lesbians and all bisexual women in Afghanistan in particular, who don't have a voice right now, who don't have, and who people don't know about their struggles. As you know, the situation for Afghan women is deplorable. They cannot even leave the house. They cannot leave for work or for any other reasons. LGBT people of Afghanistan who basically have no rights. They have no opportunities to do anything. They face constant persecution and risk in Afghanistan now because the Taliban have absolutely zero tolerance for any homosexuality to ever exist in Afghanistan. So we, in this situation, this is why Parveen now is left on her own, and Mariam, her lover, they were engaged to get married. One day when they left, she's now being tortured and imprisoned by the Taliban, and she's now been in prison for over 1 month. We have a list of over 1,000 people who still remain in Afghanistan. These are people who are vetted and approved to the best of our knowledge that they are LGBT people. Many of them, we are prioritizing those people who wish to be a human rights defender.
We are supporting different groups, the LGTB and the people with HIV, the sex workers, and the people with disability, the widows, and all excluded groups. So as the ongoing conflict in South Sudan has really disempowered this group, another group in South Sudan, they are disempowered, they are vulnerable, they are marginalized. The issue of GBV become the issue. It is widely spreading when the conflict started. So people use it as a way of triggering the war. So there is physical violence, there is domestic violence, there is also sexual harassment, sexual abuse, there is conflict, also sexual. So all those sorts are happening because of the conflict that is going on. And also, it is also used as a weaponization of rape. They are also raping women across rampantly because of the conflict. There's also increased risk for the displaced women and girls in South Sudan. And also, there is also limited access to justice and support.
Since I'm still waiting for HIV to be covered in universal health coverage, so everything is integrated. I wish my out-pocket expense reduced and systems are gender responsive.
Namaskar, मेरा नाम माया प्रकाश अनोरे है. Women with leprosy face unique and invisible struggles. At home, they are often unable to express their problems even to other women. This is not the case with men. In family matters, women are frequently excluded. Gender discrimination plays a major role here. The workplace is another area of concern. Women receive lower wages than men for the same work, which is a clear example of gender inequality. These issues are compounded by the stigma of leprosy. But perhaps the most serious impact is in the area of healthcare. Women with leprosy often suffer in silence. Social stigma, economic dependence, and a lack of agency prevent them from seeking timely medical help or sharing their experiences. This intersection of gender and disease requires urgent attention. If we want to truly support people affected by leprosy, we must also address the gender-based injustices they face every day.
Well, this was just a glimpse of the ground realities which we see everywhere, particularly in conflict-ridden areas and totalitarian regimes. Before we begin the panel discussion, I would like to invite our mentor and guide, Dr. Helices Getahun, who happens to be here today despite a very busy schedule. He is CEO of HEDPAC, an organization dedicated to strengthening South-South partnership in health development, and founder of SEDI, for his support. And he has been supporting the She and Rights Initiative and also made today's event happen. Welcome, Dr. Getahun. Please.
This was not planned. No, I'm not going to say a lot, and thank you for coming. Thank you for your interest. And Sahidi is a new organization founded here, basically to raise the right to health, the right of everyone, everywhere, regardless of gender, sex, the color of the eye, or whatever, that they have all the rights for health. And we want to actually use the right to health lens to advocate for universal health coverage, including sexual and reproductive health, services. So thank you very much, and I'm looking forward to hear the discussion. Thank you.
Thank you so
much. Thank you, Haile and Shoba, for this introduction. It was great to hear these keynote remarks by Dr. T and the video testimonials of people experiencing gender and sexuality-based violence on the ground. So I think this is a great segue into our interactive panel discussion today. We'll be focusing on the theme the human right to health and gender equality as bedrocks to advancing progress on universal health coverage. So this is the way forward at the WHA 78 and beyond. And it gives me great honor to invite our esteemed panelists today. Fadekemi Akinfaderin, the Chief Global Advocacy Officer at Feminista. We have Dr. Eli Lapat-Sabu, the Executive Director at Health Horizons International. Baba Aye is the Health and Social Services Officer at Public Services International. And then Dr. Harjot Kosha is the Senior Technical Advisor at the International Planned Parenthood Federation and a member of Civil Society Engagement Mechanism for UHC 2030. So thank you all for being here, and without any further ado, we can get the panel started. So the first question I have is for you, Harjot. What examples have you seen of effective civil society responses to gender-based setbacks in UHC frameworks?
Yes. Like after listening to our friends from Afghanistan and Iran, it is difficult to talk. And with so much right-wing uproar globally, especially in South Asia, I think like when Shobha started talking about political, so I think it's very difficult to separate sexual reproductive health, rights, justice. I want to say it all because people often are forgetting the rights and justice and even the sexual part of it. So we are in that kind of world. And when we are thinking that, yes, we need to have health systems, firstly, with the current donor crisis, we are rethinking how can we have health system strengthening. Number two, will it be complemented with community system strengthening? Number three, will it be based on community intelligence? Will it be based on getting voices, inputs, like our friends were talking, like communities who are left behind? Let me go back, like Baba and I were just talking about COVID. One thing that we saw during COVID was that people who were from the most marginalized groups were further pushed behind, like far off the margins. People coming from LGBTQI communities, women in all diversities, women in sex work, women who use drugs, young girls. There was no access. Like gender-based violence, so much was reported during COVID. And we have learned from it the hard way, that how we want to reach out, bring in the marginalized and strengthen our health systems, make them resilient so that we are able to have not just like, I'm talking about gender transformative approaches. That is something that we need to think, talk, and build our health systems on. It's high time. And with also like, and Laura will again, like in every session, I'm saying that we started this year with our UHC theme of financial protection, and look where we are. We are unable to, like we saw Daksha talking about out-of-pocket expenses. And just in the last session, we discussed that a trans woman is paying $20 a week to get HRT. A sex worker, like I tell you in South Asia, we can talk about abortion in India, Bangladesh, Nepal. And in these countries also, whereas the public health systems are supposed to provide abortion care, a sex worker is shelling more than $200 to get an abortion done. We have, as IPPF pushing, we have abortion clinics and all, but still, those who are in the far off or a sex worker, you think of it, oh, I'm a woman, I'm into sex work, oh, I have to get abortion. It is still very, very difficult. So, and then we say that how can we separate SRHRJ from politics? It's very politically driven. And especially from stigmatized, double, triple, and I don't know how many layers of stigma women in diversity are like grappling with, and where do we go with it? So, and the last point that I wanted to highlight was that we are talking about universal health coverage. And we have some amazing tools. We want to push for social participation. We want self-care, putting health in hands of communities, health in hand of women. And my friends will talk about that. We've been hushed when we are trying to talk about comprehensive sexuality education with young people. How are these young people going to know about their own sexuality, understand, reach out to your peers? How do like a young girl's right to contraceptive care? Where are we talking about it? We need that. And that is something we are talking. And then we come to countries like Afghanistan or people from like humanitarian and fragile settings. I was discussing about Bangladesh, and I don't know why it's my favorite country to talk in since morning. But I met with some like women in sex work have no access to family planning commodities or anything in Rohingya communities who are like currently living in, Bangladesh country. So we need to up our game. And I think the current donor crisis, I have to talk about it, that it has taught us to strategize, re-strategize, build up on innovations, digital health, whatever it is. But we need to bring it back to have our health systems strengthened, but always base them on community systems centering approach. Yeah, thank you.
Thank you. Thank you, Harjat, for emphasizing this work is inherently political. So next for you, Dr. Ellie. I want to ask, please tell us how can health systems be adapted or redesigned to better protect marginalized groups such as LGBTQ community or migrants within the framework of universal health coverage?
Absolutely. I want to start with a short exercise, and I want all of you to close your eyes. Also, the people at home, don't fall asleep. I want you guys to imagine going to a hospital and being denied a service just because you don't have the right paperwork. Imagine being a girl that wants to have access to a vaccine, and you're denied that service just because of the color of your skin. Imagine being a victim of sexual assault and you go to the police and they turn you away because you are not considered a citizen of that country. Or just imagine a woman trying to go to get mental health support and you cannot obtain that because they don't speak your language and they cannot understand you. And now I want you guys to open your eyes. And those are the realities that I face on a daily day as executive director of Health Horizons International. Our organization prides of being the only organization in our country that defends and advocate for access of healthcare. And although we live in a country where health access and universal health coverage is part of the norm, it's not accessible for everybody. So it's built on a foundation of discrimination, especially against women of color and immigrants. This, for example, this photo is just a patient of ours, and this is a Haitian woman that is undocumented. And just not to get into details about the historical relationship between Haiti and Dominican Republic. These are two countries that share the same island. This woman was diagnosed with cervical cancer, and we connect her to services to treat her cancer. However, she was turned away just because of the language. Then we got her a translator to go with her, and they said, okay, now we can understand you. However, you don't have documentation, so we cannot treat you. And she said, what are my options? Perhaps palliative care and just die in your house. And as I listen to a lot of the stories that happen across the world, especially in the South Globe, it really resonates with me because our fight to get to universal health coverage is far from finished. So through my work and a lot of the things that I have encountered, one of the things that I said is, to bring this to high politicians. Imagine me, of course, a gay man, flamboyant, and also a refugee going into the doors of the ministry in my country and asking them to consider a proposal that we have to create this program called Movimiento Mujeres, where we train women in our community to identify women that can be screened for breast cancer and cervical cancer, and then connect them to the services. And I remember the first thing they said is, no, that will never happen in our country. I mean, this is accessible for people that have citizenship, which is great, and that makes us universal and public, but we cannot see immigrants. So I said, okay, watch me get it done. So I found this program called Movimiento Mujeres, and our goal, I click somewhere where I should not click. And our work is something that is very particular, because one of the foundations of our program is we wanted to create a program that reflects who we are as a community. And this is not a program that is a cookie cutter program that we took from another developing country and tried to implement it in our country. This is a program that is very Dominican, for Dominicans, by Dominicans. So part of the responsibility is, and this is something that I've always encountered as very important, which is investing in community-led programs. So this is a program that is where we identify young women in our community to be educators, to be healthcare providers, and they connect with other women. We have been able to break down a lot of the barriers regarding the language by also hiring people that are from Haitian nationality or Creole speaking, just to break the barriers in terms of education. But beyond that, one of the things that we have, I will say that have made us very successful as an organization is that we recognize vulnerable population as right holders and not burdens. And I think that's a lot of the challenges that a lot of governments have. I mean, this is a small country with limited resources, yet we want to call ourselves to be equitable and accessible when we are not. And I feel like when we are building a system that excludes women, children, people of color, we're building a system with a broken heart, and we should do better than that.
Thank you, Dr. Ali. I think it's important to say that people are not inherently vulnerable, and vulnerability is something that comes from being excluded from a system. So thank you. Fadekemi, next, I want to ask you, how does gender-based violence undermine UHC? And what are scalable interventions to address this?
No, thank you so much. So, first of all, my name is Kemi. You can call me Kemi for short. So first things first, I work for Force Feminista. It's an international alliance of over 130 organizations coming together across the global south with a shared vision and a shared agenda to shift the needle and shift the conversation, including care, including political advocacy on sexual reproductive health, rights, and justice. And so we do have core areas of our work, and gender-based violence is one of those core 5 areas that we're extremely committed to see to the end of gender-based violence. So I know that you asked me about how is it that gender-based violence impacts the achievement of UHC. I want to look at it in the other way and flip it to see how can universal health coverage actually help us to end gender-based violence, because that's really the focus of what we want to do. And so, but just to look at some of the like framing and core issues that's really important. One, we know that survivors themselves need access to healthcare services. And we know that that's actually restricted for a wide variety of reasons, including financial barriers, including lack of capacity of the health system itself to be able to respond, including, social barriers like stigma and discrimination. But also, let's not also forget the fact that the healthcare system has also been a site of violence itself. And I tend to think about my experience as an educated, I would say well-off, middle-class woman And when I had both my kids, I was denied access to epidural. And I was denied access to epidural in a health center on the basis of the fact that the healthcare worker wanted me to give birth like a Hebrew woman. I don't look Hebrew at all. But it just helps you to really think about it. If I, as a very privileged woman, can experience that form of discrimination and violence in the healthcare system, then what would happen to those that are criminalized and on the margins? And so I see universal health care coverage as a means to an end. The end is access. It's not about the coverage. And I think many of our governments have forgotten that. They focus so much on the coverage, but that does not necessarily guarantee access. And so if we are really able to expand access, then the reality is that the healthcare system is well positioned to be able to support ending gender-based violence. And so I want us to look at it in terms of where are the opportunities there. Of course, we already know, and I think this is already a given, the fact that GBV services need to be part of the essential health package that is delivered as part of the health system, and particularly at the primary healthcare level. And we know that many governments have made strides to make that happen, but more needs to be done because you still have situations where, for example, commodities are not readily available at the primary healthcare level, and that you also have healthcare workers themselves not being adequately prepared, even though the guidelines and the frameworks exist. The second thing I think is around the economic barriers. And so we've worked many times with different sort of healthcare, like private service healthcare providers. And one of the challenges there is like looking at the cost for providing, cost for PrEP, cost for emergency contraception, which is not always available in most countries. And so we need to look at how can we eliminate those barriers to accessing essential services. The other thing, as we've been pushing towards the advocacy for universal healthcare, we've talked also about the importance of integration and comprehensive service delivery. And GBV services need to be part of that integration and comprehensive delivery. And I think stronger coordination can actually make that happen across the system. So instead of having siloed GBV services, which we've seen a lot, also happen across the global south, in which you have GBV centers totally separate from the health system, we need to look at greater connection to that. And when you talk about issues around access to legal services, there are circumstances in some countries that you need to actually access care in a public facility for you to be able to access justice, because the evidence generated would not be admissible in court if it's not generated from a public health system. So I think also the linkage between that and access to justice is really critical. And then, of course, as my wonderful brother from Dominican Republic have already shared, the issues and the needs of those that are most criminalized and on the margins. I gave my example, and quite honestly, it's like a walk in the park when you think about the day-to-day lived realities of those that are most criminalized: sex workers, people living with disability, trans people, and queer people overall, migrants. And I think this is something that we tend to overlook all the time because it's like, okay, we can't be there for everybody. No, we do have to be there for everybody. Otherwise, it's not universal. And the final thing I would say on this question is we need to also think about how can we leverage the health system and the health system's infrastructure to help us to really challenge the root causes of gender-based violence. What are the opportunities to be able to use to leverage community healthcare workers, to be able to really do some of that gender transformative work at the community level to really change the norms and the systems that perpetuate and actually expand on violence itself as part of a unique opportunity. So I think I will stop there for now. Thank you.
Yeah, thank you. Thank you. And access to the health system isn't enough when the system is re-traumatizing or further marginalizing people. So what you said about community healthcare workers and primary healthcare needing to be comprehensive is leading me to my next question for you, Baba. I'm wondering if you could tell us what are frontline health workers reporting in terms of the impact of anti-gender policies on healthcare delivery?
Thank you very much. First, two quick things. Public Services International, because I've had some people thinking I was talking of the other PSI. It's a global union federation that brings together 30 million working women and men delivering public services in 155 countries. 14.7 million of this being health and care workers. And the second thing is with UHC, I know the general understanding of it as universal health coverage, but I think it's part of the problem. I think it's not accidental that the C stands more for coverage in the official language. When you look at also the increasing piece of health insurance in the broader, so I feel more comfortable with seeing it as universal health care. And I think this better links us more with the spirit of the Alma Ata Declaration. So now, with regards to the question, there are two dimensions I'll look at it. The first is with regards to those health and care workers serve. And the other, and I'm happy you spoke about community health workers, it will be a key aspect of what I'll speak to. Because, I mean, you can't really talk of universal health care without health workers for all. It's impossible. It doesn't make sense. Well, talking of the place of anti-gender policies, a number of people have spoken in one way or the other to the, I think it was Harjot initially, abortion. About 13% of all maternal mortality are from unsafe abortions. And for health workers, especially in countries where abortion is criminalized, and don't forget 2/3 of health workers are women. I mean, this itself is it impacts it doesn't, it's not just that the issue of the mental health of even the health worker not being able to stop such from happening, not because they align with government position, but because it's illegal, they can't do it. It's a major problem. But also, and I have had this with, I worked in Nigeria before, and the major, some of my colleagues, community workers in rural places, express how bothered they are by the fact that you have a lot of young girls, young women and girls in school, in rural places, having to use rags for menstruation period. I mean, in a number of countries, the issue of menstrual rights is a given, you know. And we did try with Medical and Health Workers Union of Nigeria at a point in time to push that, okay, if you could have things like condoms in toilets, we should be able to have things like pads. And then the Commissioner of Health, they say, of all the problems this is what you are talking about. Are you people serious? Then I was an organizing secretary, and I was like, this is something, and they said, no, it does not matter. So these are some of the things that as health workers, members, and some of us on the field do see. That I'll speak more with regards to the health workers themselves, and particularly community health workers. You see, when we talk about healthcare delivery, it's not just about the centrality of the worker, it's about, people have spoken about the feminization of poverty in a number of contexts. One key aspect of it is with regards to community health workers as volunteers. In so many countries, we said that women are 2/3 of health workers generally, but in so many countries, community health workers is a synonym for women workers in the community. In fact, even the names in Pakistan, you have the community health workers are LHWs, lady health workers. You know, the ashas in India are all women. The same thing within Nepal and so on and so forth. And when the whole idea of community health workers came up with Almata, where I started the discourse from here now, it wasn't to be cheapening of cheap labor. It's like they've been used as people that work upwards of 40 hours plus a week are then considered as volunteers. And that's why I was very happy. I had the privilege of being on the WHO Guideline Development Group on Community Health Worker programs. And one of the key things was that, look, you cannot consider people as volunteers when they work normal working hours. But despite this, we are still fighting in most countries to get that position to be respected. So when you don't get that kind of pay, it dampens morale. That is not the only thing. Female community health workers face harassment, rape on the field, and this impact on their ability to, if in the first place, it impacts on even their own health, because it's when we talk about universal healthcare, there used to be this question: then who cares for the carers? It also needs to be put in perspective. And lastly, with regards to understanding, because anti-gender policies themselves should be situated within a broader context, especially the socio-political context. For example, you see in a number of countries, particularly African countries, the governments playing the divisive card of passing anti-LGBT plus laws to divert attention from, their economic policies failures and things like that, because they believe that it will find some echo. You understand? So similarly, increasing confidence of governments to push anti-gender policies is within a rising spate of right-wing politics. A rising spate of, heteropatriarchal, sentiments, and these things are, intersectionality is not only on the progressive side. They blend together, that and racism and, and misogyny, they blend together. So we need to see the different faces of the same enemy, and the impact of this on health. And for us, that is very important as PSI. And we think that a key aspect of speaking to this is fighting for gender transformative public services, at the heart of which will be universal access to quality public health care.
Thank you, Baba. We have one more round of questions for our panelists before we open up to the audience. So if I can ask you, Harjat, how do UHC 2030 mechanisms better integrate sexual and reproductive health rights amid political resistance?
Okay. So one thing is that there can be no UHC without sexual reproductive health rights and justice. If you're talking that, we need to have the political will and we need to bring in communities together and let's push for UHC. Oh, you need like SRHRJ to be the first push to start for UHC at field level, country level, global level. I think that's the first thing we need to get clear. Second, as my friends were talking about so much about communities, we cannot forget our health systems are defined, made for heterosexual, married, good couples. So that perception and the level of stigma or misogyny, which Baba correctly said, I think that is something that we grapple every day. And you think about a young girl going to a clinic and talking about, that I need a contraception or I need an abortion service. I don't know how many countries it's happening. Because again, coming back to Bangladesh, last year we saw this big pushback on LGBT communities in Bangladesh. Oh my God, it was crazy, led by young people. Why are we not investing in young people? As we need to strengthen our UHC agenda, we need to strengthen our health system programming, we need to invest. Invest with comprehensive sexual education, exposure, invest from that level. Then talking about frontline workers, in a country like Sri Lanka, we still have laws like MDMA, Muslim Marriage and Divorce Act, where 8 or 9-year-old girl can be married off. As CSOs, as activists, we are pushing for it, but we need that investment, and it cannot happen without we going in front and talking about the structural barriers, the punitive laws that are holding our society back. So it's a very like a mixed form. And last point, when it comes to frontline workers, in a country like Sri Lanka, if a frontline worker is in street and walking with condoms and needles for women in sex work or for people who use drugs, he can be put in jail and we will not even know where that person is. If you look at, the policies and all, Sri Lanka was the first one in our region to come up with the PrEP guidelines, and still there is no PrEP in the country. So we are looking at countries want to progress, country wants commitment to confirm on commitments, but how many commitments are getting realized at field level? That is something as CSOs, as community leaders, we need to keep on pushing. Of course, it has got little difficult since January after we all have been trumped, but we'll get there and I'm very hopeful. So thank you.
And thank you for the hope. It's necessary. So, Ellie, for you, I want to ask, given the current global backlash against gender and human rights, what practical strategies can be implemented to ensure inclusive and rights-based approaches, ensure that inclusive and rights-based approaches remain central in national UHC policies and practices?
Absolutely. Well, first, before being a health worker, I am a lawyer. And one of the things about being a lawyer and working also in the health field is that we see that interconnectivity between law and human rights and healthcare access. I feel like if we want to build a UHC system, we cannot build it just on the basis of coverage, but in context. I feel a lot of our countries are very different and they experience different processes through history. For example, in our country, a lot of the social determinants of health are very different and they differ from other countries. So it has to be built to responding on the needs of the country. Earlier, I was mentioning about something about policy in the realms of embedding rights into policy and not programs. In our country, one of the things that are not very successful is that equity and programs that had to be related to gender equity are just programs, something temporary for 3-4 years, but that the actors in the public health system or in the public government institutions are not interested in integrating that into our laws. So I think long-term, our goal, and this is of course for as a lawyer and also for my people in the health work field, is for every initiative that is designed as a program towards health equity, especially gender equity, to long-term, the goal should be to integrate that into the constitutional or to the recognition as a law. The second thing is, and this is something that is super, super useful, is disaggregated data through studies or anything that we use. It is super useful because that allows you to comprehend the population that you're serving. Sometimes monitoring and evaluation systems fail in the sense that they miss on a lot of people because they don't have the right way of measuring or studying the population that they're serving. Again, an example in my country, access to vaccination is free, but free doesn't equal accessible. So sometimes we have clinics that are set in remote areas that are inaccessible for a lot of individuals. The materials are created in Spanish, so people that don't speak Spanish don't know what is happening in these events. And then when it comes to the vaccine, if you don't have the proper documentation, you cannot get vaccinated. So again, that program, although it has a great intention, is leaving a lot of people outside of access to that specific service. The third point is protecting spaces for young queer, young immigrant women and children. And the reason why I mentioned that and I emphasize this point is because with everything that is happening in the country right now, for example, if an immigrant person goes to seek some service to a hospital, they can receive the service, but as soon as they are healed, they are deported. So hospitals and health centers have become these basically liaisons of deportation centers, and that of course increase the fear and the stress of a lot of patients that are seeking these services. So one of the things is emphasize on firewall policies that can really protect individuals and their information, and that increases trust in the community for people to go and have access to these services in a space that is safe and it doesn't compromise their integrity as human beings. My next point is in regards of making sure that UHC is designed from the community, and one of the things that my peers were mentioning is the importance of, for example, the CHWs, the community health workers' voices. And this is something that we do through our work. At the end of the day, the CHWs are the ones in the field. They have a comprehension of the challenges that our patients are facing. So we design our programmatic framework based on the needs of our patients because of the voices that we elevate in the CHWs. And that brings me to the next point, which is investing in frontliners workers. Small organizations like ours are usually suffer from the backlash of government. We don't get funded, and sometimes we are pushed back a little bit. But what we represent is something that just the fact that we're assisting is an act of defiance. The CHWs in our communities deserve to conduct their duties in a safe, protected environment. They deserve to have proper compensation as well. And most importantly, that governments and authorities recognize the importance they have and the role they play in ensuring accessible to and affordable health services. And lastly, one of the things that I just growth based some of the things that my peers were mentioning is the role of men in ensuring health equity. I get asked a lot of that question whenever I go to panels or events, which is, you have found this women's program, but you are a man. Like, what is your purpose? And I feel like men can also become allies, and they can challenge a lot of the harmful ways of thinking. In Latin America, for example, the machismo is something that is very predominant in all of our policies, and our systems were built in colonialism. They were built on the suffering of people of color, women. Therefore, they are very heteronormative. So I feel like a lot of men, and through the journey of my organization, we have identified a lot of people that are powerful, that can at least open those doors to, of course, elevate the voices of women and powerful individuals that are marginalized in our communities. And just my last remark, and this is in regards of me as a lawyer, sometimes not because something is legal, it means is fair. Sometimes countries fall into this commentary that they do recognize universal health coverage or they have access to public health, but not every time these policies are accessible for a lot of individuals. So a lot of trapdoor policies are implemented in the way to have to kind of like affect specific groups and marginalized groups. But again, by funding initiatives that can address those challenges and provide sustainable solutions, I think that we can definitely make more concrete, ideas and things that we bring in panels to take it to action. And I've always said it's not only about being preoccupied, it's also about occupy yourself and provide sustainable solutions.
Absolutely. Your focus on sustainable and accessible community-based UHC is bringing me back to Baba's distinction between UHC, that's coverage, versus care. So Kemi, for you, I'm wondering, do you see new opportunities for progress towards multilateral funding for women's health initiatives in this changing global landscape?
So you're gonna hate me very greatly.
I could never.
Because I'm gonna flip the script again by not being a great panelist and listening to instructions. Because I think we need to situate the issues around multilateral funding within the context of the growing pushback is not the word, but within the context of the growth of authoritarianism, the erosion and attack on democracy, and I would say the exports of anti-rights and anti-gender ideology across the globe. So we are seeing it in countries in the North. We're also seeing it being operationalized in the global South and the connections in between. And I'm not to create a dichotomy, because I think we need to look at our issues in a holistic way and really shed a little bit of the geographical boundaries, but recognizing that there are peculiarities that we need to be attentive to. So I hope that everybody in this room knows about the Geneva Consensus. And I hope that every single person in this room knows about Protego. So maybe I should ask the question. How many people know about Geneva Consensus? Can you just raise your hand? Perfect. How many people know about Protego? So slightly less. So then I'll focus on Protego. So as many of you know, Geneva Consensus is a rallying tool. It's not a negotiated treaty, all of that stuff. It's just literally a club of people or countries coming together and saying, this is going to be our shared political agenda. But the challenge is in how they're operationalizing it. And Protego is a project that helps to operationalize the Geneva Consensus. Valerie Huber, who is the co-author or author or brain person behind the Geneva Consensus, also has an initiative called the Women Optimal Health Framework. The Women's Optimal Health Framework is the intervention that she is selling to governments to be able to, quote unquote, deliver on maternal, child, and adolescent health. When you look at that document, you will see how much it resembles the global strategy on women's, child, and adolescent health. So it's extremely challenging and complicated for our governments, our ministers, to be able to unpack and say, hey, something doesn't look right here. Because on paper, even I was like, my God, this is good. Not good in the sense that this makes sense because it's not built on evidence or science. But in the writing of it, I was like, oh my God, this looks good. Now, the challenge here is that we're seeing more and more governments play into this narrative of we want economic sovereignty, which I don't have a problem with. We want health sovereignty. I have questions there. We want cultural sovereignty. I have some questions there, depending on what is the definition of culture. But we're also seeing the anti-rights and anti-gender movement use that same frame. And just 2 weeks ago, is it 2 weeks now? 2 weeks ago, I'm sure many of you saw on the internet the fact that there were all these anti-rights, anti-gender conferences happening on the African continent, and literally from Uganda from Entebbe to Nairobi. Many of our partners were there, some of our staff was there, and really following the conversation and trying to better understand what is their narrative and what about our language are they co-opting and using. And they're using all of this. They're using universal health coverage. They're talking about the right to health. They're talking about, like I said, economic sovereignty. They're weaponizing the concept of family to be able to push this particular agenda. But indirectly, what they're trying to do is erode and undo everything we've done and challenge science. They're the same people that are anti-vaxxers. They're the same people that actually have funded, and some of them we know have had situations and cases around early child and forced marriages in their context. And so how is it that we're able to build, and I say resilience in a loose way here, resilient health systems to be able to push back against these narratives and push back against interventions that are not based on science, that are actually cooked up in people's minds as a way to appeal or to advance a particular type of agenda, but that is detrimental to all the progress that we have made as a community around a variety of issues. They even have their own CSC curriculum that they don't call CSC, you know? And so how do we arm governments to be able to recognize, and, Nandita and I had a long conversation around pseudoscience this week, and how this is also an emerging area of work that we have not paid attention to at all. And they're basically cooking up their own studies to justify some of these interventions. So it's like using the master's tool to destroy the master's house. They're really taking advantage of these things. And it's something that we need to be on top of and work together with governments, work together with healthcare workers, work together with frontline vendors, because we also know that they're actively recruiting midwives, community health extension workers to be able to advance their anti-abortion, anti-CSC agenda as well. Last year, they had a big training in Nigeria focused on midwives. They went to a school of midwifery to challenge the curriculum. How is it that the government of Nigeria did not stop that training from happening when it goes against the national guidelines? So these are the things but they went there and said, we want to train midwives. Nobody's looking at what they're training midwives on. So these are the things we really need to think about concretely. Otherwise, everything we've spent our time on will be absolutely lost. So I hope I did okay and did not offend you by flipping this clip.
Thank you so much. We love critical thinking here. So I want to ask you, Baba, sort of related to Kemi's answer, how can health system workers and members of civil society work together to defend and promote gender equitable health systems? And in the interest of time, I would ask that this answer be a little quick so we can have some time for maybe 1 or 2 questions from the audience.
All right, I'll try to be quick. Yeah, I will be quick. But I think it's also to look at how to do what you do. It's important to stress the fact that whilst we appear to see just a rupture with where we are now, there's a strong thread of continuity with where we have been coming since the 1980s. The neoliberal incarnation of capitalism, it wrecked what Ken Loach described as the spirit of 45. And I think even what Kemi was saying, the issue, there are a lot of interconnectedness. I'll try keep them tight. For example, part of why you can have the soil for the poisonous macabre flower we are seeing, of which, I mean, the Trumpesque part is just one of the petals, maybe the most colorful orange-colored one. But it's much more than that. You see, part of what happened with the rise of religiosity in Africa, this both Islam, Christianity, Pentecostalism, evangel, these were sort of, people spiritual booze for the material madness and suffering that came with privatization, liberalization, deregulation as the generalized reality of life for many. There's strong continuity. Now, where we are and what is to be done, it's at different levels. At the local, at the national, and at the global, the multilateral. We saw the other time the kind of push. For the first time, you had a sharp debate at the within the WHO governing bodies over application for official relations of a non-state actor. Why? Because this was a non-state actor that stood for sexual and reproductive rights. It never happened before. What is that? They've gotten the forces on the right have gotten bolder, and in the interest of time, I'll just capture it all with story I said. This was in 2010, and it was in response to how things went after the global financial crisis, and it was that I expected more. This was since the Great Depression, it was the worst economic crisis, right? But after the Great Depression and all that, you had a social compromise, you had a Keynesian welfare nation state, but this time you had the governments insisting that we take more of the concoction that cost the ailments as the remedy, right? Now they are even making that concoction worse. It's because we haven't been bold enough with our demands. There's a lot of focus on the technical, on the small rocks as against the big rocks. And the story I said then, and which is what I'll end with, is if you are in hell and you try to negotiate for a better place in hell from the devil, he realizes that you are not serious at all. But if you're in hell and you fight like hell to get out of hell, even if you don't succeed, you will come and negotiate to put a fan or an air condition for you somewhere. That is what was at the heart of the 40s of the post-war order. So we need to be bolder in our demand. They have been bold. We need to move forward. We need to see and link the different issues together in a powerful and bold manner. This is not that time for us to be, genteel or limited to the workshop. We also need to take the streets. We need to be out there. We need to put it before their face that another world is possible. A world where the right to health is, pursued. A world where gender equality is pursued and won. And I stop there.
Thank you so much, Baba, for your urgency, and the foregrounding of intersectionality is something that keeps coming up with your intervention. So I really appreciate that. Do we have any questions from the audience?
I'm going to go ahead and take a couple at a time in the interest of time, and then we'll ask the panel if they can respond to all of them at once. So we'll start here.
Hi, thank you so much for your interventions and for sharing your knowledge and your time with us today. My name is Leah Birch. I'm a medical student from Canada, and I'm here with the International Federation of Medical Students Association. I have so many questions. My first one, I'm just so inspired by the last words that were said, and I was wondering, how do you balance, especially in this moment where we are now, where it's very scary. I have this United States as my southern border, very scary. But my question particularly is, how do you balance communicating with your patients about protecting their safety, because often it comes down to their lives in these situations, and their lives are at risk when they seek out their rights. So how do we balance patients getting access to their rights and their basic health care, but also staying alive? And like, how do you like work within the system, but also challenge the system at the same time to protect our patients? I guess is where my question is coming from.
Another hand back here. Go here and then here.
We want to give a practical example of data segregation. I think, Eliezer, you mentioned about it. I used to work in the eye care program focusing about cataract operations. And in my country, every year you have that figure, how many operations the country did. So when I was working, I just asked, I get a cumulative number. Can you just tell me how many males, how many females? There was no answer. Fortunately, we had 5 pilot districts. I come from India. A district is a very big size. We had 5 pilot districts. So we started collecting this basic information that when a person comes of surgery, is it male, is it female? Next year was something very stunning. 64% of the people who came for surgeries, mostly the old persons, so where there is no apparent discrimination. 64% were males, 36% were females. So for us, it was not just the diagnosis. We said, what should we do? So we started organizing the things which are much more tilted towards the females. Like in a surgical operation, if there is a fees, we said if the females are coming, there will be 0 fees. When males are coming, they pay that fees. We started organizing the female dedicated eye camps only for the females. It was not so much about numbers. It was much more to give out the masses that you don't have to neglect that old lady in your house when next time you're trying to bring somebody to the eye camp. Bring both of your grandparents instead of one. And if you can bring only one, think of your grandmother who's probably having both eyes blind instead of bringing your grandfather who's going for your second eye surgery. I just wanted to give a practical example of something which you just mentioned. So data segregation is not just is contextual. At times you can blow it up into the practicalities. No question.
Thank you. And we'll take one more over here.
Thank you, and thank you to all the speakers. I have a question for all of you, because the conversation we have here, as Kemi mentioned, a little bit threatened by conservative parties that triple down their propaganda down into organizations, government, and even hospitals or midwives, apparently. So my question is, how do we keep having a discussion with those that are promoting unequal and discriminative view on healthcare? And is that even possible? I mean, as you said, Baba Aye, it is also about being bold and not being gentle anymore. So I'm curious what is your view on that conversation, having that conversation?
I think we pass it back to the panelists now.
Excellent. So first question. One of the things that I see as a challenge with both health providers and patients is the lack of knowledge and education when it comes to law. Just to give you an example, with everything that happened in the States, one of the things is a lot of people were feeding on the social media and kind of like consult on ChatGPT on what things to do and how to navigate either segregation through in health facilities. But most importantly, a lot of people receive information in a way that is filtered and is not always legit. And the other thing with the health providers is sometimes physicians and nurses, of course, are in a setting where they are obligated to follow instructions, and they can also be victims of either being harmed or being affected if they are defending somebody that is being discriminated. So, for example, in our country, there are mechanisms that are legally designed to destroy the career of physicians and providers that dare to provide support for undocumented individuals. Those can be either financial ways of harming them or taking their license away. So a lot of people feel afraid. But most importantly, I feel like people need to be equipped with the right knowledge around how to navigate these challenges, but of course, always prioritizing their safety. It's very difficult to talk about being safe when you don't have access to healthcare neither. So, for example, just to put you in context with a recent situation, this woman was supposed to go and give birth. She have all her documentation, so she had two choices: either give birth in the Dominican Republic and be deported to Haiti, or go to Haiti, understanding the context of where Haiti is right now, which is very unsafe for a lot of individuals, especially people in the diaspora, and of course give birth in Haiti, but running the risk of being killed. So it's not a decision of like what dressing you should put on your salad. It's very, very complex. But what it comes down to is that people need to be informed of what are their rights, identify organizations or institutions in the country they live that can advocate for them, be informed by legal professionals as well in anything that had to happen. And the most important thing that I tell my patients is not wait to get sick until you start accessing information about your rights. I feel like we wait until emergency cases where, of course, your legal situation is not a priority in that moment because you might be sick, but it's so important for you to be educated, not only the people that are undocumented or are vulnerable to immigration policies, but people that have citizenship or they don't have those vulnerability that also can support those people that are marginalized. Absolutely.
The second question that let me, I didn't quite get the point there of that you talk about my speaking being bold. I was distracted. I'm sorry. Please repeat it. I was hoping because you said it was to all of us that maybe when Fadekemi was answering, I'll get a better key of what you were saying.
That's okay. I think the question was about how do we have a dialogue with people who are pushing back on what we consider fundamental human rights? Is that about it?
Thank you. How do we dialogue? You see, maybe as a unionist, I mean, that's the problem. We are both involved in negotiation. But we also do know that you try to negotiate from a position of strength. And that is why, like what I was saying earlier, I think over the decades, we have gotten more used to workshops than rallies. I was talking about the spirit of 45 and the context of it. You to realize then you had matches, that was when in the United States of parts of North America, you had the sit-ins. That was when you had the CIO, and things like that. For me, one of the most deflating moments was when you had the global financial crisis and the World Social Forum that had been saying another world is possible. It kind of fizzled out. But long story short, from what you're saying, I agree there might, and let's also, they are not a monolithic body. But the thing is, there is this hegemonic core amongst them that are diehard right wing. There's this alpha male movements salt, you have, so you have quite a couple of them, and they are hegemonic. So the thing is, drawing from Gramsci, when period of what you call a war of position, how do we consolidate forces? How do we challenge them? How do we challenge the ideas they stand for? So I think that is primary to there will be those to dialogue even now with, but I think we need to fight against these ideas more than talk with them. Like what I was saying about the devil, you don't see, I mean, you exercise it, huh?
Thank you.
Thank you, panelists. Thank you for a very stimulating conversation and for giving us hope in this era of darkness. There is still hope, and I'm sure we will see light at the end of the day. And now, let us listen to a short video message from Nazneen Damji, Chief AI Governance and Participation Section of the UN Women and Senior Policy Advisor, Gender Equality, HIV and Health at UN Women.
Excellencies, distinguished delegates and colleagues, as we commemorate the 30th anniversary of the Beijing Platform for Action this year, we are called to reflect not only on how far we've come, but how far we must still go. The Beijing Declaration was a bold promise to the world's women and girls that their rights, dignity, and health would be non-negotiable. Today, that promise remains unfulfilled. Universal health coverage cannot be truly universal if it does not prioritize gender equality and human rights. Health systems that ignore the unique needs and barriers faced by women and girls are not only unjust, they are ineffective. We're facing a rising coordinated pushback on women's and girls' health and rights, particularly their sexual and reproductive health and rights. In just the past few months, we've seen drastic funding cuts impacting not only civil society and member states, but also UN agencies that provide abortion care and life-saving HIV treatment. This is not just a budget issue, it is a crisis of political will. Let's be clear, sexual and reproductive health and rights are not optional. They are fundamental human rights, and yet only 56% of married women aged 15 to 49 can make decisions about their own reproductive health. This is not a statistic, it is a reflection of deep-rooted structural inequalities and harmful social norms that continue to deny women agency over their own bodies. The consequences are devastating. Every 2 minutes, a woman dies from preventable pregnancy-related causes. In 2023 alone, over 700 women died each day from complications that could have been avoided with access to quality care. Meanwhile, HIV incidence among adolescent girls and young women remains alarmingly high in parts of sub-Saharan Africa, where they are more than 3 times as likely to acquire HIV as their male peers in at least 22 countries. These are not isolated issues. These are symptoms of a global system that continues to devalue the lives and health of women and girls. The newly released World Report on the Social Determinants of Health Equity confirms what many of us already know. Gender discrimination blocks access to healthcare. Even when user fees are removed, women, especially those who are young, poor, migrants, or from ethnic minorities, still avoid care because of abuse and mistreatment. And in this context, we must recognize the vital role of women's rights and civil society organizations. These groups are often the first responders, delivering life-saving healthcare, protection services, and psychosocial support to survivors of violence. Yet their ability to serve those most at risk, especially women and girls facing intersectional discrimination, is becoming severely hampered by shrinking funding and growing backlash. But there is also progress, and that must be celebrated. This year, at the 69th session of the Commission on the Status of Women, member states adopted a political declaration reaffirming their commitment to the Beijing Platform for Action. This is a powerful reminder that women's health remains a key priority on the global agenda. It's a moment of renewed momentum, and we must seize it. And also, over the past 2 decades, we've seen real gains. The number of women using modern contraception has doubled, and the unintended pregnancy rate has declined by 19%. These are victories worth protecting, but to sustain this progress, we must invest in and scale up the best practices that got us here. We must ensure that UHC is not just about coverage. It must be about equity. It must be about rights. It must be about justice. That means guaranteeing access to comprehensive sexual and reproductive health services, including contraception, safe abortion, maternal care, and HIV prevention, which requires increasing domestic financing for health systems and ensuring that women's health services are integral to health benefit packages. It requires protecting and funding the organizations and movements that defend these rights, and most importantly, putting women and girls at the center of health policy, not as passive recipients, but as leaders and decision makers. The Beijing Platform for Action gave us the roadmap. Now, 30 years later, it's time to deliver. Because health for all must mean rights for all. Thank you.
Now we move towards the first inaugural She and Rights Media Award ceremony, which is online. We do not have any of the recipients here, but they will be receiving the award online. Kelsey, please do the honors of hosting this.
Thank you so much, Shobha. Thank you to Baruch for the excellent moderation. And can I get one more round of applause for our excellent panelists? I've been to a lot of side events this week, but I think this was the most moving and energizing panel. So thank you so much for being here with us. We are running a little bit behind, so I'm going to go as quickly as I can. But it is my distinct honor and very great pleasure to be announcing the winners of the first annual She and Rights Media Awards. We do have a QR code, so I won't spend too much time telling you about She and Rights, but please do have a look later at the initiative. She and Rights is an initiative founded by the Global Center for Health Diplomacy and Inclusion, CEST, and CNS, which works to engage and educate journalists and media actors to report on issues related to sexual health and rights and justice in a sensitive and evidence-based way. Before we announce the winners, let me just tell you a little bit more about it. This is co-hosted with IPPF, WGNRR, Arrow, and APACT Media to build and sustain increased media understanding about these very sensitive and under threat issues that we're facing. And we've been really focusing on reaching journalists and media actors in the Asia, Pacific, and African region to help them form a network of journalists that can report on these issues the way they deserve to be reported on. So from September of last year to March of 2025, there were over 280 unique media sources, URLs, and links from 21 countries that raise these issues in media. And now we are going to be honoring some of that excellent reporting with the awards we give out today. So I'm very pleased to announce the first winner of the prize, which is Miss Ojoma Akor, health editor of the Daily Trust newspaper in Nigeria. And we have a few words from Ojoma now. Turn it up.
Do weird sound. Okay. Our apologies to Ojoma, but as I said, this will be available online later, so please do have a look at the incredible reporting, which is also available. The next winner in second place is Miss Catherine Morubedzi from the Express Mail in Zimbabwe. Our congratulations to Catherine.
Hi, issue by raising awareness and inspire action. Trying to marginalized voices. I'm advocating for policy changes and that everyone has access to the child care they deserve. For me, right, sexual reproductive health and rights is about telling the human story, bringing the full that voice of the forgotten woman and forgotten girl. Let us work together to create a more just and equitable world for women and girls. Thank you.
And the third prize goes to Miss Kalpana Acharya from Health TV Online, Nepal.
My journey as a journalist has been driven by a deep commitment to telling the stories that often go unheard, stories that reflect the challenges residents, and rights to people across the country. As a journalist, I believe that gender equality, gender justice, and the right to health are not just issues, they are fundamental human rights. They ensure that every voice is heard and every life is valued. Thank you.
We have an additional 5 special mention prizes. We would like to congratulate Mr. Babacar Sene from Agropasteur in Senegal. This is in French, I believe. Next, we have Miss Audrey Galawu from Zimnow, Zimbabwe. Miss Betty Herlina, the editor-in-chief of Bintang Perempuan, a Bahasa language media of Indonesia. Miss Yenakao Satsetsu from KISS FM radio in Nigeria. Next, Miss Hamu Banzeze, the editor of
Thank you so much.
Health Diaries in Zimbabwe. And that's it. Yeah, we apologize for running a little over time, but we do encourage you to have a look at all of their profiles on the website. And finally, we just want to thank you all so much for your attention and to our great journalists for participating in the program and bringing these issues to the general public in a way that is science-based, accurate, and promoting the right to health. So we have our very final words now to close the session. I'm going to hand it back over to Shobha.
I would now like to invite Dr. David Parithiriatwa, Senator and former Minister of Health, Zimbabwe, and President of ICASA for ICASA 2025 for his closing remarks. Welcome, sir.
Thank you very much indeed. Let me thank the organizers and the co-sponsors for this very important function, and also the panelists who really were very stimulating. But I'm from Zimbabwe, and you saw quite a few. One from Zimbabwe. It was nothing to do with me. I can assure you they just won. The alma mater in 1978 spoke about primary health care. And now it's called universal health coverage. It's really the same thing. In real practical terms, it's primary health care, which must now continue to be emphasized. And you remember that in 2000, before 2000, we used to say health for all by the year 2000. Of course, when 2000 came, we said health for all beyond the year 2000. And then 2001, the African heads of state gathered and spoke about HIV and said 15% of your budgets must go to HIV. Very few African countries have covered that now. Only 3 have done so since 2001. So it shows some political unwillingness. Now the slogan is no one should be left behind. And that is important. And I think we're leaving a lot of people behind. So we need to transform. Because universal health coverage is cross-cutting. It's really not just a health issue. It's really cross-cutting. So we must transform health settings. We must transform political willingness. We must transform the religions. We must transform our morality. Our morality, our social media, all those things are compounding some of the things that we see. If you see the abuse on social media to some of our women, it's disgusting. So we need to transform all those things. We must transform the workplace, the home place. All those things need to be done. And I think that's what we should be doing. Should we be teaching these things from grade 1? Maybe. Maybe we should do that. As people grow up, they absorb what should be done. How about the legalities? Our parliamentarians should lobby the appropriate things. And this has been said here in very, very powerful words. International platforms like these ones, these are important, Shoba. These are very important platforms. It's unfortunate that your workshop was not well attended, but it should have been full here. And I think you should find a way of making it full next time, because the messages that are coming from here are very, very critical. Another international platform is ICASA. You mentioned ICASA. I'm the president of ICASA. We're going to have ICASA, which is usually attended by 10,000 to 12,000 people. And this time is going to be in Ghana, in Accra. And I urge you all to, especially the students who came, to come to Ghana and see what is happening in terms of fighting for equality. So I really want to just summarize by saying, let's protect and promote special groups in our communities. And we must do that deliberately. LGBTQ must protect them. As far as I'm concerned, if we're fighting HIV and we don't look at that, we will not win the war. We must do that. We must be able to open up and support that. Prisoners, we often ignore them. Migrants, it's a big issue now. And I think we must look at that. Disabilities, but more importantly, poverty. People are just marginalized because they are poor. So be rich so that they are not marginalized. But that's not good. There are a lot of poor people. Widows, sex workers. And now it's a trade, a respectable trade, sex work. So we cannot marginalize them. Racist attitudes is very strong. You must question yourselves, are you not part of that? So that you also are fighting against discrimination. There are many others. But most importantly, who will coordinate this fight? Who is going to do it? Are we coordinated in fighting it? Who is the body? Is it you and women? Is that the right one? And when we fight, are we using, I think my colleague there in a head, he said, let's be militant. Is that the way we should be going? Or should we be negotiating our way? These are things that we need to put on the table. But most importantly, who is going to lead this fight and coordinate it properly? But I want to thank you for organizing this, and I wish you all to go with that word that is not yet over. We must continue to fight. Thank you so much.
Thank you, participants, for being here with us. And let us hope we carry the words forward, what was discussed. And a big thank you to the panelists once again. Thank you.
I will run now. I have a flight tonight. Yeah.